Hi, it's Dr. Ronald Lett from the Canadian Network for International Surgery. Today, we're going to look at the topic of emergency venous infusion, specifically tibial access. What are the indications? Inadequate vessels, inadequate perfusion in trauma or obstetrics, or in children. So shock is the major indication for venous access, and when you don't have adequate access, the tibia is there for you. Contraindications are limited. A fracture on that side of the tibia, the femur, or even the pelvis is a contraindication. Sepsis, where you would be placing your intravenous line, is also a contraindication. There are two alternatives in tibial access. One is interosseous infusion. The second is Saphenous vein cutdown. We will demonstrate both of these in this tutorial. For tibial venous access, you need to know some lower leg anatomy. First of all, the bone. Bone has a cortex, a marrow, and veins. When you do interosseous infusion, you go through the cortex into the marrow, which is attached to a very extensive system of veins. Thus, infusion into the marrow is as good as into those veins. The lower leg has superficial veins as well. The biggest one, the long saphenous, goes from the groin to the ankle. So for tibial access, you need to identify certain superficial anatomic positions. Let's start with the tibial tuberosity. The tibial tuberosity is identified by finding the patella. The patella tendon inserts into the tuberosity. You go 2 fingers below the tuberosity and just a little bit over to the flat part of the tibia. And this is where you can insert your interosseous needle. If you are choosing to do a long saphenous vein cut down, you have to find it. You find the medial malleolus. You go 2 finger breadths up, 2 finger breadths over, and that is where you will find your long saphenous vein. So for tibial access, lower leg superficial anatomy is important. The tibial tuberosity for interosseous infusion, the medial malleolus for long saphenous vein infusion. For tibial access, you need to practice how to put in an interosseous or how to put in a long saphenous catheter. So we'll start with the interosseous infusion. We have a model which has representation of a knee, tibial tuberosity, and a location for inserting your interosseous needle. This model here has skin and subcutaneous tissue. Interosseous infusion is a sterile procedure. I'm wearing sterile gloves. I'll prepare the skin with sterile solution. We have a fenestrated drape to keep the procedure sterile. If the patient is awake, we would take local anesthesia and infiltrate the skin. If they're unconscious, it's not necessary. So we put in a little bit of local anesthesia. You can put a nick in the skin to make it a little bit easier to get through. We have a number 16 needle. There are all sorts of special devices. You're not likely to have those in Africa, certainly in the under-resourced setting, but you will have a heavy needle and you will have a needle holder. And using a boring action, you can insert it. You feel it give as it goes through the cortex into the marrow. You would irrigate it to get any pieces of marrow out of the bone, and then you can do an infusion. This is a life-saving measure that you use for up to 24 hours while you're stabilizing the patient, and during that time you can get peripheral venous access. We will continue with another skill involved in venous infusion in the lower leg. This is the long saphenous cutdown. We have a model where we can practice this skill. You need a landmark. Your landmark is the medial malleolus. From here, you go 2 finger breadths up and 1 finger breadth across, and that is the site of where you make an incision. So, let's give some local anesthesia at this point. Again, 2 fingers up, 2 fingers anterior, and we infiltrate the skin. Now we make an incision. We dissect into the skin, into the subcutaneous tissue, and we look for the vein. Sometimes it's easy, sometimes not so easy. And there I see the vein. Dissect a bit more to make it more visible, a bit on one side, a bit on the other side, and then I try and get my artery forceps underneath the vein. There's adventitial tissue that has to be spread, and this model has adventitial tissue as well. It's been a little bit difficult, but there is the vein. Now, you want to control that vein, just like you would any other vessel. So, I do that with a suture. I loop the suture, grasp it with the artery forceps, and pull it under the vein. I need 2 sutures, so I'm going to cut this one and make it into 2. And I put an artery forceps on one end and an artery forceps on the other end. And we now have control of the vessel. You can put any IV of your choice in there. I'm just going to use a catheter. I'll lift it up, insert it in the vein, advance it, take out the needle. I'll then attach it to an intravenous. I want to be careful that I don't lose the site. If I have an assistant, I'll have them hold it. Otherwise, I will just get another suture and take my needle holder and suture it in place. it's not quite lying flat, there is another place to suture on the catheter on the other side. So I'll utilize that to get my IV laying down flat, which will assist in infusion. Now, I have the catheter secured in place. I'll tie the vessel off above, but very loosely, because you don't want to crimp the vessel and have no infusion possible. So I'll just loosely tie the controlling vessel above. And then we will do it below, and it can be a bit tighter. So we now have a long Saphenous cut down. We put on a dressing, and we secure that dressing in place. And if you're a little concerned about the catheter itself, you might want to put another piece of tape on it to control it. So there you have a long Saphenous cut down where you can infuse fluids quickly in the trauma patient, in the obstetrical patient with hemorrhagic shock, or in the child who needs venous access, perhaps for non-traumatic reason, but for dehydration and all their other vessels are flat, you will be able to find the long Saphenous vein. One pointer about the child, again, it's 2 finger breadths above and 2 finger breadths anterior to the medial malleolus, but it's not your finger, it's the child's finger, and that will give you your landmark.
Thank you for watching, and please follow us on Facebook, Twitter, Instagram, and be sure to subscribe and like us on YouTube. If you would like more information about CNIS or on how to become our member, please go to www.cnis.ca.